Good morning and welcome to our monthly webinar. I'm Dr. Meredith Warner of Warner Orthopedics and Wellness and also founder of the Well Theory. And today we're going to talk about common orthopedic surgeries. I'm sort of going to give you an overview of how common they are, why they're done, the actual kind of outcomes, and how to avoid them. That's the goal of this talk. So what are the most common or some of the most common orthopedic surgeries? And what we can do to potentially avoid them. But if you have to have them, you have to have them. We'll talk about the outcomes. So avoiding recovery and natural ways to treat the underlying problem that leads to these common surgical indications. All right. I did. I already introduced myself. This is my clinic in Baton Rouge, and I have a heavy focus on trying to help people avoid surgery unless it's absolutely necessary. Because most of the literature has kind of shown me in the past decade or so that people do better if they take care of the foundational problems that lead to the orthopedic problems, which is chronic inflammation, oxidative stress, poor nutrition, poor sleep, poor mindset, things like that. And we're going to briefly talk about all of that today. So common orthopedic surgeries, and this is primarily focused on the United States because, of course, we do the most surgery. So about $70 to $100 billion a year is spent just on orthopedic surgery in this country that we're aware of or that's been measured with large databases. Most commonly, it's going to be your knee replacements, your hip replacements, knee scopes, shoulder scopes, ACL or anterior cruciate ligament replacements, shoulder replacements, a lot of spine surgeries done, far more than anywhere else in the world. And then various joint fusions, and then also little things like carpal tunnel release are fairly common. I put this slide in here to show you how Medicare reimbursement for orthopedic surgery over time has changed. So the graph on the x-axis starts in 2008 and goes to 2021. And then the y-axis is the percent change, 0 up to 100. So this is reimbursement. So what does Medicare pay for certain orthopedic procedures? And what I wanted you to notice was that the pay has gone dramatically up for hospitals and dramatically down for the doctors. So most of what's going on today is driven by hospitals and industry, not by physicians, mostly because of this fact. So they have continually decreased physicians' reimbursement for anything that we do, far greater than the rate of inflation, and they continually increase what they pay the hospitals. So I'm not sure if that makes sense or not. I'm sure somebody much smarter than me in the government is making these decisions. But I just thought that was an interesting fact that you should know. But still, we're up to about 100 billion on orthopedic surgeries. Okay, so I've been curious over the past decade or so, why do people seem to want surgery, or why do they really choose to have surgery? Since I know that a lot of these surgeries really don't do that well, statistically speaking, and from what I've seen in the community and in all of my various experiences. I've been a surgeon for the military, I've been an academic surgeon, I still am, I've been in private practice, I've worked for a group, I've worked for hospitals, so kind of seeing all of the different ways medicine is applied, and in most cases, the outcomes are not as advertised. Surgeries are very, very expensive, and they take up a lot of people's time. Limit your ability to work, dramatically decrease your overall wealth in time. Surgeries are not without complications. A lot of times there's infections, there's post-op pain, there's some swelling, things don't always go as we plan, nobody has a perfect result, et cetera, et cetera. And then again, I just showed you the slide where the payers are valuing the work done by surgeons at a lower and lower rate over time. So I just wonder, why do we do it, and why do patients want these surgeries? Something I've just been curious about, and this talk is sort of just delving into that. This is an image from Civil War medicine. I wrote a report when I was in, I don't know, 4th or 5th grade, and my mom kept it. That's why I know I did this, on Civil War medicine and orthopedic surgery in particular. So I guess I've kind of wanted to do this for a long time. That's a surgical set from an orthopedic surgeon in the Civil War. See, it was a very limited tool set and focused mostly on a saw. So we have advanced a lot since then. Our surgeries are a lot better, but they're still not perfect. So knee and hip replacements. Traditionally, you probably think they're done for wear and tear. Most physicians still think they're done for wear and tear. And that's been sort of the marketing shtick to to get these things done. Oh, you've worn out your joint. You've been standing on concrete your whole life. Or, oh, you work so hard, or you've been playing sports, or, you do too much exercise, et cetera, et cetera. That's been our traditional indication to justify replacing a joint with metal and plastic. It's very expensive. It's very debilitating. However, recent and not so recent, actually, we've probably known for at least a decade that it's not wear and tear. What is happening at the cellular level to the collagen and the cartilage, and this is a micrograph of 2 nanometers showing you these structures. Oxidative stress is destroying the architecture at the microcellular level. Chronic inflammation, likewise, destroying the cartilage and the connective tissue around it. And then there's a lack of micronutrients because of our diet that doesn't allow your body to have the things it needs to heal itself. Lack of sleep, things like that. So really, we are doing this to ourselves with lifestyle. It's not so much that we're doing too much physically. In fact, as I'll show you, the opposite is true. So the highest prevalence, supposedly, of osteoarthritis in the globe or in the world is in the United States of America. We are the most advanced economy, and also we are the least active of all people on the globe, meaning we just sit on our butts, we're on computers, whatever, food's delivered to us, we drive everywhere. Basically, we don't do anything unless we really, really try to. So we're the least active, yet we have the most osteoarthritis. So that alone should dispel the wear and tear myth for you. So about close to 10,000 per 100,000 people here are diagnosed with osteoarthritis formally. Now, I'm sure the prevalence is much higher. It seems to affect women more than men. And again, historically speaking, women are less likely to work and also less likely to engage in sports. Again, another thing to dispel the wear and tear myth. So can it really be wear and tear? I don't think so. And I think the literature backs me up, particularly the basic science literature. There's some new genetic information coming out that shows that there's some people that are more prone to forming pro-inflammatory proteins or mediators. And then also there's some genetic things that play into how your skeletal muscle mass and your collagen develops, which again is connective tissue. Collagen is the protein that is a fundamental building block of all connective tissues. And then again, with genetics, that has nothing to do with overuse. Whether or not you're lifting weights your whole life, you're some sort of high-level extreme athlete, or you're a desk worker, right? It's just you're sort of set up into this category where your conditional probability of getting arthritis is already elevated. And then if certain things happen, like poor diet, poor sleep, lots of stress, you're going to probably get it more likely. And this is another micrograph of a cell being put into a collagen bed to try to promote growth of cartilage. It's just, there's so much research being done to try to find a non-joint replacement cure for arthritis. We do not have a cure for arthritis. State of the art now is to remove the arthritis and replace it with metal and plastic, which is what we do. So knee and hip replacements, pretty much the most common surgeries done, okay, for ortho. In 2022, there are 1.3 million total knee replacements. This is up 51% from 2021, so over a year, increased by 50%. Now, does that mean activity levels increase that much? I don't think so. In 2008, there were only 615,000 done, which was a 134% increase from the number done in 1999. So we are just exponentially doing more and more joint replacements. In 2030, it's predicted that we will do almost 3.5 million joint replacements that year, okay? The prevalence is gonna be in your 50-year-olds, 4.2% of your 50-year-olds since 2013. I'm sure it's much more now. This is just 2013 data that I was able to get. 4.2% are gonna need a joint replacement, or are gonna be indicated for one, I should say. Now, that is a picture of a total joint replacement, okay? The hand is holding the part that goes on your shin bone or your tibia. The plastic is the white piece. That's what the two metal pieces articulate on. And then the curved thing goes on the end of your femur bone. Underneath is the title of an article that I put to tell you that I don't think these numbers are right. I think the rates are going to dramatically go down because of our newer anti-obesity meds. This says liraglutide, a glucagon-like peptide-1 receptor agonist, GLP-1, exerts analgesic, pain-relieving, anti-inflammatory and anti-degradative actions in osteoarthritis. So GLP-1s are reducing kidney disease, diabetes, obesity, dementia, heart disease, and I think also they will reduce the incidence of osteoarthritis. Why? How can it do all of this? How can there be such a wonder drug? Because it helps with the foundational problems of insulin resistance, which damages your mitochondria, oxidative stress, chronic inflammation. That is the foundational core problem of all of our lifestyle diseases, be it arthritis, diabetes, whatever. So I think the more these anti-obesity meds become prevalent and the more people take them, you're going to see fewer joint replacements. So check back 10, 20 years, see if I'm right. Okay, in 2022, there were 766,000 total hip replacements, which is a 3.8% increase from 2021. 2000 to 2010, the rate had doubled, okay? And in 2025, it's expected to be about 652,000 a year. Again, about a 2.3% chance if you're 50, some doctor's going to tell you you need a total joint replacement, a hip in this case. 30% of these are now being done in people under 55. Now, that would have been unheard of when I was training as a resident. Nobody would have thought of putting a total joint in somebody in that age group. Now we routinely put it in people in their 30s and 40s. So we're doing more of them because maybe our scope of indications has increased. We used to limit it to over 60 or over 65. Now we're saying, oh, no, you're 40, we can put a total joint in you. So that effectively expands the market for total joints. And I think that's one of the reasons you're seeing more and more of these. So again, the common narrative is it's wear and tear. I think most of it is the fundamental issues that I always talk about, that the well theory is built around, which is chronic inflammation, oxidative stress, mitochondrial dysfunction, and insulin resistance. But everybody always still says wear and tear, that you're too active, that you overused it, yada, yada. But more and more physicians are starting to recognize that obesity may play into this. However, most physicians still think obesity matters because it's more load or heavier weight put on the knee. What obesity is really doing is it's constantly producing inflammation. So your adipose tissue is a factory that never shuts down, and that factory makes pro-inflammatory cytokines or proteins. And so your fat cells are attacking you all day long without rest. And your body is always having to fight back, which in most cases doesn't have the building blocks it needs to fight back. So the dramatic increase, this is a title of the article I wanted to highlight. The dramatic increase in total knee replacement utilization rates in the US cannot be fully explained by the growth in population size and the obesity epidemic. So people are looking at this very closely. Is it wear and tear? Probably not. Is it obesity? Probably, but maybe not fully. So all we know is there's been a dramatic increase in rates. I think part of the problem too is the indication creep. So in other words, it's no longer just 65 with end stage arthritis. Now it's 55, now it's 50, now it's 40. Earlier and earlier stages of arthritis. And I'm going to show you some more information a little bit later that shows you how switching what the payers will do also has increased the rates of total joints. So Stryker, which is one of the biggest American companies that makes these implants, their global sales of total knee arthroplasty in 2023 was $2.2 billion. In quarter one of 2024, they had revenue of $588 million, and the profits were estimated at $359 million. So this is a very profitable business for the companies that make the implants. Not really for the doctors, kind of for the hospitals, but really for the companies that make the implants. Younger patients now. So obviously you want to expand your market share, right? So now we're indicating younger and younger patients, and we're saying it's because they're more active. But I already told you that the United States has the least active people in the world, yet we have the highest incidence of arthritis. So that doesn't really make sense. Basically, we, the doctors, are indicating people more and more often and sooner, and you just have to ask yourself why. All right. We've already talked about how the obesity rates have increased dramatically. We know this. Everybody knows this. Kind of goes without saying. I think that increases your chronic inflammation, oxidative stress. There's more insulin resistance. Cartilage can't perform properly. Cartilage can't heal itself. the little hard surface of bone underneath the cartilage starts to get cysts and defects and become osteopenic, and that hurts. There's all kinds of problems with your connective tissue system that stem from these fundamental foundational problems of insulin resistance with mitochondrial dysfunction. I think that's the real reason we're seeing an increase, but also the marketing is much better. We've got more direct to consumer advertising. There's just more penetration of industry into the FDA and other decision makers at the government level. The population has increased, but that doesn't seem to be the reason why. And then the real well, not the real reason, one of the main factors, I think, is that the insurance companies aren't really covering any other options anymore. So when your whole decision-making process is predicated upon what the insurance is going to pay to do for that patient, it kind of changes your decision making. So in other words, all things being equal, let's say there was an unlimited pot of money for this patient, you might choose X, Y, and Z, but all things aren't equal, and the insurance company is saying, I will only pay for A. Therefore, typically, you choose A, because most people aren't going to pay out of pocket for the alternative type of treatment. And right now, the insurance companies seem to be pushing surgeons down the total joint replacement pathway. So what is the typical cost of a total knee? For Medicare, it depends, and that depends on regions. So they value some regions higher than other regions. Medicare will value it at about $1,500 to $3,000 or $3,000. Okay, so not a lot, much less than you probably ever thought. Private insurance, I did this little quick math, assuming there's a $7,000 deductible that you have, which a lot of people do nowadays, and assuming there's a 20% co-insurance rate after you meet your deductible. The out-of-pocket cost for most total joints average around $6,000 around the country for private health, and with a total knee replacement costing $30,000 generally, that's what the group health pays. So you can see it's far more than what Medicare pays. But that out-of-pocket cost of $6,000 is just for the surgery. It doesn't pay you for the time off of work, the part-time when you do go back to work, the presenteeism because you don't feel quite right at work for a while. Nothing about the pre-op or post-op physical therapy, nothing about the medications that you need, nothing about the dressing supplies, nothing about the durable medical equipment or like the bracing or other things that you might need. And of course, any pre-surgical costs like MRIs or anything like that is not included. So having a total knee arthroplasty is a major financial decision, but most people don't realize that. The average sales price of a total knee, now this is the company selling the implant, is about $5,186. 34% or 1/3 of that is the cost of goods, the cost of actually making the total knee to the company, storing it, and then shipping it to wherever it's used. About 40% goes to sales and marketing. So that's your sales rep, customer service, TV ads, ads in magazines and newspapers, things like that. About 7% goes to research and development. And then there's miscellaneous costs. So the sales rep gets anywhere between 15 and 25% every time a surgeon puts in a total knee. So they're making as much or more than a surgeon does to put in a total knee, which is kind of bizarre if you think about it. That's how much money these companies are making, that the rep gets paid at the same rate or better than your total joint surgeon. And remember, the surgeon is paid not just to do the surgery. That includes the pre-op visit, post-op visits for 3 months. And then nowadays, Medicare is doing this thing where they say that there's an overpayment or there was a never event, like say somebody slipped and fell at the hospital or they got a blood clot or some complication like that, then Medicare is going to go in and pull back that money and you don't even get paid for the work you did. So it's kind of, I think something's going on where there seems to be forces that want us to do fewer and fewer of these, but ironically, we're doing more and more. I personally can't reconcile the two. I don't think I have enough data to do that. I think there's a lot of information that is not out in the nether to gather to figure out why this is going on. But I just wanted you to know how expensive these implants are, $5,000, and how most of the money is going back to the company, not the doctors, and maybe or maybe not the hospital, depending on how they bill and code for it. So why are more people diagnosed with arthritis and indicated for these surgeries that are quite expensive and debilitating and a big financial hit? Again, we are less active than we ever were in the United States of America, but the rates continually go up and up and up. Our rates of arthritis are higher now than they were even just a few decades ago in this country. Our rates of arthritis have doubled since 1940. Now you tell me, do you think we are more active now than people were in 1940? I would say definitely not. So why do we have all this arthritis, and why is it so bad that it's being indicated for joint replacements? Like there's nothing left to do except literally remove the joint and replace it. You have to wonder why. So I just put this very busy slide to show you, not to go through it, but just to tell you the complexity of what goes into healthy joints. And really it comes down to the balance that the body is always maintaining. There's always a process of mild microscopic injury during the day and damage from different things like pollution. Maybe you did have a little twist and, an impact injury. Maybe there was some cartilage slammed with the jump from height, whatever. The body is able to handle this and fix it and repair it, but it has to have a very coordinated, orchestral almost movement of different proteins and different enzymatic reactions that are all very much timed, very linked to your circadian rhythm. They require a certain amount of micronutrients. Your vagal input has to be appropriate. In other words, you can't have too much parasympathetic or sympathetic nerve input. You've got to have the proper balance of strength and flexibility. A million things go into a healthy joint, okay? The least of which wear and tear. The body was definitely built to handle activity. In fact, it functions better with the more activity we do. So actually, we don't wear and tear enough, honestly. That's why we have so much arthritis. And then the radiograph shows you what a normal knee is. That's actually probably grade 1 arthritis on the left. And then an osteoarthritic knee, that's grade 5, okay, bone on bone, so to speak. And then here's a micrograph of some cartilage with some frayed edges on the top. We now recognize that osteoarthritis is a whole joint systemic disease and not really ever affecting just one joint. So I'll give you an example. So we used to say obese people would get knee arthritis because they're so heavy they're wearing out their knees. However, all the studies have also shown that the same obese people that have knee arthritis have finger or hand arthritis to a much greater degree than anybody else. Now, are they walking around on their hands? Typically not. So this means that it's a systemic problem, and it's not so much that any particular joint is being overloaded, so to speak. Again, disproving the whole wear and tear concept. We have this whole osteoarthritis initiative data set, so this long-term data that's been collected on people, and people are starting to go into those and use machine learning and deep learning and segmenting out different bits of the knowledge. So part of this database is even pieces of cartilage that have been sent into a central repository from arthritic knees that are replaced, and then people can go in and run studies on that information. So the cartilage thickness has changed over 8 years. And we think that some of this may be related to the shapes and features of the meniscal tissue around the cartilage. And that's associated with a slight increased risk of getting arthritis. So I just put this in to show you that this is new information. So even the shape of your meniscus, which is of course genetic, right? How you end up having, what's the wedge of your meniscus? Is it a 8 degree versus a 10 degree? Or do you have a true semicircle, or is it more of like some sort of alternate shape? All of this matters with who's going to develop arthritis or not. It's not simply load and activity. So we have traditionally thought that cartilage has a very low capacity to repair itself, or a low intrinsic repair capacity. This has been disproven now. We know that cartilage can heal itself and repair itself. You just have to give it the appropriate paradigm and it will function that way. If you don't, it will not repair itself. So I guess in a way, because most Americans have not provided the body with the ability to repair itself, it can't. So in a way, that old thinking is right. It's just that it's wrong. If you give your body the sleep, the micronutrients, the low stress, the positive neural input, things like that, you will repair your cartilage from any microscopic damage that occurs throughout the day. Stem cells seem to help a lot. This was blocked by the FDA a couple of years back. So now if you want stem cell treatment, typically you have to be really rich and able to fly outside of the country to do it. I've had patients come ask me for it, and I tell them, sorry, the only way I can do it is if I get it from your own bone marrow with a drill and put it into your knee. Most people don't want that. So they leave and go to Nicaragua or Panama or Costa Rica or Germany, places like that, and get their stem cells. Hopefully this will change soon, but as of right now, that's really the only way to do it here. Subchondral bone failure is associated with arthritis, so that has to do with bone quality. Bone quality has to do with exercise and micronutrients, vitamin D deficiency, things like that. So if your bone that's sitting right under where the cartilage is poor quality, by definition, the cartilage is poor quality. We've also learned that there's a communication between the subchondral bone and cartilage. We don't really fully understand it, but we've recently learned that bone is an endocrine organ, meaning bone releases proteins and substances that communicate with the rest of the body, to include the brain. For instance, low levels of osteocalcin have been associated with dementia. So people that have healthy bones, and strong muscles have a lower rate of cognitive decline when they get older. We're starting to understand that there is this communication. We don't really understand exactly how. One theory is that potentially some oxygen that is released from the subchondral bone can stimulate the onset of oxygen, so some linkage there. Again, we're not really sure. The infrapatellar fat pad inside the knee is also involved. So that is right behind your patellar tendon under the kneecap. As you enter into the knee joint, everybody has this big glob of fat that sits there, and it itself can produce inflammatory proteins and cytokines, just like the rest of the fat in the body. It doesn't normally do that, but in certain conditions it will. I've had patients where I actually inject that fat pad with Toradol, which is sort of it's like a liquid ibuprofen. That's how I think of it, to sort of try to reduce the inflammation that fat pad's releasing. And that seems to help in some cases. It's not for everybody. But we think the infrapatellar fat pad, the subchondral bone plate, the lack of stem cell or cartilage repair capacity, all of this is playing into why we're seeing more and more total joints and why Americans have such a high rate of osteoarthritis. There's also been found pro-inflammatory cytokines. All that means is proteins that induce inflammation. More and more of them are being located in the synovial tissue. We used to think osteoarthritis wasn't inflammatory at all, but we were comparing it to things like lupus and rheumatoid arthritis. Now we know it is inflammatory. It just has different biomarkers that don't show up as intensely as when you check for rheumatoid and lupus and things. But the pro-inflammatory proteins, are the ones that induce inflammation, also inhibit the capacity of cartilage to repair itself and enhance the destruction of cartilage. Incidentally, just so you know, so do steroids. So if you get repeated steroid injections, you're actually damaging your cartilage over time. I try to shy away from steroids if at all possible. In some cases, that's all you have to give relief to somebody. And again, in most cases, that's all the insurance companies will cover. But if I were you, I'd try to avoid steroids unless you absolutely need it, because there is some evidence, a lot of evidence, that over time cartilage damage connective tissue. So the extracellular matrix, you may or may not have heard of this. Very, very important. Every tissue type depends on its extracellular matrix. So bone has a certain type of extracellular matrix. Bone is primarily type 1 collagen. So are many other things in the body, but based on the extracellular matrix, the function of that collagen changes. So your extracellular matrix of cartilage is actually going to be different than bone, same with nerve cells, same with muscles, so on and so forth. In cartilage, the proteoglycans, which suck in and hold water, the collagens, which are the proteins that give you the structure and strength, tensile and compressive of the body, the non-collagenous glycoproteins, all of these are put together in a different combination that make cartilage cartilage. One of the reasons you may get the gel or the rooster comb injections, perhaps you've had that or heard of it. The brand names are Synvis, Duflexa, Monovis, etc. This is hyaluronic acid injections. The reason we put that into people's knees is because that is a component of the extracellular matrix. Hugely important component. anti-inflammatory, increases the viscosity of the joint, and then provides a bit of a building block for cartilage intrinsic repair. So I love HA injections far more than steroid injections for people for those reasons. So matrix mineralization in your bone depends on the extracellular matrix. Manages the proteases. These are the proteins that go in and chew up and degrade collagen. What does that matter? Well, that's how you destroy cartilage. And then the collagen structure itself depends on the extracellular matrix. If you chemically decellularize or remove the cells from the extracellular matrix and you treat with enzymes, you can make an osteoarthritic solution. So the reason I put this in here is there's a lot of drug companies working on injectables to try to reduce the degradation of cartilage in arthritic joints. We're not there yet, but they're starting to find more and more proteins that really help with this. So again, back to my main point, I think between the anti-obesity drugs and all of this new research being done, I think the total joint replacement industry is going to plummet, is my prediction, I hope, because to me, these are better options. And then if you have increased reactive oxygen species, which are what you may remember from other talks I've given, reactive oxygen species just means there's extra free unpaired electrons or free radicals floating around. Reactive oxygen species is the byproduct of dysfunctional mitochondrial energy production, okay? So insulin resistance leads to this. So if you have insulin resistant cartilage in your knee, you're gonna have altered mitochondrial function, you're gonna have more free radicals floating around. The more you have that, it's gonna damage the extracellular matrix, and guess what? Everything's gonna fall apart, and now you got osteoarthritis. So anything we can do to reduce the pro-inflammatory cytokines in the joint, reduce the free radicals in the joint, and provide the building blocks and the environment for proper repair to help the extracellular matrix, the less surgery will be needed for these arthritic joints. Fewer surgeries. So one thing that people are looking at is inhibiting VEGFR1, which is vascular endothelial growth factor receptor 1, I think, and 2. With the inhibition of these particular proteins, these are new drug research that's being done. There was decreased pain and progression of arthritis, and there were no significant side effects seen. There's a nano PAZ2. This is FDA approved for cancer therapy currently, novel nano coatings. So they're trying to combine these two things to make some sort of injection to treat arthritis. I don't think it's at even the phase 1 or 2 level with the FDA yet, but I'm just telling you, there's work going on right now that's really going to help you dramatically in the future. We know mitochondrial dysfunction is extremely important, so anything that helps a mitochondria is going to help. NMN, resveratrol, controlling your glucose levels in your bloodstream, anything that upregulates AMPK like metformin or berberine, anything that makes your mitochondria better is going to help your arthritis. And then we think of arthritis like we think of chronic wounds. So I see a lot of diabetics in my clinic with chronic foot wounds. What is happening there, why it can't heal, is the macrophages think that it's always a chronic inflammation phase. They never resolve the inflammation. In other words, the normal cycle of healing events is halted kind of at step 2. And there's this constant turnover of inflammation, and they never enter the remodeling and rebuilding phase. That we think is part of the problem with arthritis. So if there's a way to convert it from the chronic inflammation to an acute inflammation stage where the body restarts and begins an actual healing cascade, that will help too. We just have to get out of this chronic low-grade inflammation setup, which most Americans are in because of our diet and lifestyle. So all of this may make you wonder, it makes me wonder, if we don't really even know why people have arthritis, because we always said it was wear and tear and too much exercise and activity, but well, that doesn't seem to be true. But maybe it's genetics, but maybe it's these proteins, or maybe it's this, maybe it's that. If we don't really know why they have it and why they hurt, how do we know what the best treatment option is? Right now, our options are really fuse the joints, whatever arthritic joint it is, or replace the joint. That's what we have. And that's why most of these surgeries are happening, because most doctors don't really think about or have any other arrows in the quiver. That's all they have to shoot at this problem. Same thing in back pain. Nobody really knows why the back hurts. No one's ever proven why people have low back pain. It's massively common. Well, we don't really know why it happens, but we have a treatment, we confuse it, so that's what happens. I just wonder if this is maybe the best way. I don't think so, but I could be wrong. I just wanted you to start thinking about it with me. So why should you try to avoid total joint surgery? Well, I'll tell you, 34%, and this is in the literature, of people after they get a knee replacement state that it doesn't feel normal. Now you may say, well, duh, because it's not normal. But people expect it to feel normal. So when it doesn't, they're surprised. And this is 1 out of 3 people that get a total joint. 1 out of 5 have dissatisfaction and like major problems or issues with the total knee. So that's 20%. This is what I tell my patients. You got a 20% chance if everything goes perfectly, technically, and the radiographs look good, and there's no infection, and you don't have to have another surgery, like a perfect surgical result from a surgeon's perspective. Even with that, 20% from a patient's perspective aren't going to be happy. There's going to be residual pain, stiffness, instability, something's just not quite right. And a lot of them go on to needing more surgery later or more chronic treatment. So if 1 out of 3, it says it doesn't feel normal, and 1 out of 5 aren't happy at all, and we know that there's residual symptoms and problems in anywhere from 30 to 50% of total joint replacements with or without robotic surgery. There's a crap ton of marketing out there about robotics. It doesn't matter at all for outcomes, just so you know. So if your surgeon uses a robot, great. If your surgeon doesn't use a robot, it doesn't matter. It doesn't change alignment on outcomes. It doesn't change outcomes. It doesn't change pain rates. It doesn't change really anything that matters clinically from a patient's perspective, just so you know. Are they cool? Yes. Residual symptoms and problems, total knee, up to 50%. 34% of people doesn't feel normal. 20% hate it. Now, from a surgeon's perspective, in all of the literature in the total joint world until recently, the outcomes have been awesome. So 100% great, right? X-rays look good, no infection. We didn't have to revise it. Great result. That's the surgeon's perspective, and that's been the predominant body of knowledge. More recently, something called patient-reported outcome measures have entered our literature and are now being required to use in a lot of cases for research, where you actually don't look at it from my perspective, or do I think the X-ray looks good, or if all my technical check boxes been checked, but we're looking at outcomes from your viewpoint, or what does a patient really think? So from the patient's perspective, from these patient-reported outcome measures or PROMs, these types of studies, the outcomes have not been so great. From the surgeon perspective, they're awesome. So we know that patient dissatisfaction after a total joint replacement is pretty common and is growing. So that's something you need to keep in mind when you're thinking about doing a total joint replacement. So what does cause a pain? We don't really know how people get arthritis. Do we even know if that's the source of the pain? This is a very busy slide. All it is showing you all of the different reasons a knee might hurt that we are aware of. Patellar subluxation, patellar tendonitis. You could have a medial collateral ligament sprain. You could have a hamstring bursitis. You could have a prepatellar bursitis. It could be the joint capsule. It could be the periarticular muscles. It could be a tight hamstring here, a loose IT band there. It could be the IT band. It could be the subchondral bone. It might be the meniscus. There's a million things that hurt in the knee. And if we can't really tell you exactly which one it is, and then our option is to slice everything out and put metal and plastic in, is that really the best way to handle this problem? I don't think so. So inflammation is a huge part of it. We do know that. So, and this inflammation isn't like the inflammation when you slice your finger accidentally in the kitchen. It gets red and swollen and hot. That's acute inflammation. That's the first phase of the healing cascade. That is important, and you need to have that. If you didn't have that, you would be able to heal nothing. I'm talking about chronic low-grade inflammation, really from diet and lifestyle and lack of exercise, things like that. So we've been able to identify the presence of certain biomarkers in the knee, and this is actually a much better way to predict the presence of arthritis than our current tests, which are X-ray and physical exam, right? So IFN, or interferon gamma, interleukins, I can't even say the word, IL-6, MCP1, which is I think a matrix metalloproteinase and MIP1 beta, all of these very esoteric little pro-inflammatory proteins, people are able to measure now, and it's extremely predictive of an inflammatory condition like osteoarthritis. So it's very present in painful knees and very not present in non-painful knees. So we don't really have a test for pain, but we're starting to get closer with this sort of a protein. So if we could test for this panel, if I had that ability, if an insurance company would actually cover it, let's say you came to my clinic, your knee hurt, I got some fluid out of your knee and I sent it to the lab and this stuff showed up, could be reasonably assured that you do have an inflammatory problem and we might need to address it. If all of these came back negative, I could be reasonably assured that the problem is outside of the knee joint itself and one of the connective tissues surrounding the knee. And maybe we would focus on that. So it's a much better test than the MRIs, the x-rays, physical exam, but it's usually not covered. I don't even know if the labs in Louisiana know what those are, honestly. But I just bring it up as something for the future. Again, hopefully we'll get better and better. This picture is actually something called a DTI, or diffusion tensor imaging. I've tried, and there is no ability in my state to do this type of imaging, but in some areas in the country, you can get the specialized MRI imaging that'll show you all of the collagen structures of any given area or all of the nerve elements of any given area. And you can get much more detailed, indirect anatomic information that will help determine the true source of pain. So this is showing the muscle mass of somebody's calf. And you can tell if there's areas where you've lost muscle that you shouldn't have, or little areas of atrophy, or even areas of fibrosis or thickened collagen or thickened connective tissue or fibrosis. I am trying to get DTI in at the teaching hospital where I go in New Orleans. So far, not able to do it, but it is possible. And I think this will be much more prevalent technology in about 5 to 10 years. This is a great image that I put here because this is one of the ways that I treat a lot of nerve pain. Most pain, or all pain, is in the brain, right? And the only reason your brain has any signal to even interpret, whether it interprets it up or down, is because it has to get an electrical signal from the periphery. So your knee has to send some electrons to the brain for your brain to know something's going on in the knee. This is a map of all of the nerves that innervate the knee. If you block certain ones of these or inhibit them, you can tell the brain that knee doesn't hurt anymore. Brain, nothing to see here. Ignore that. Basically smoke and mirrors. So there are ways to manage the pain without actually changing the structure of a native knee. So somebody can actually keep their own knee, so it's always going to feel normal to them, and have less pain. If you can figure out that the peripheral nerve sensory, let's say the inferior middle genicular nerve, let's say that's a source of pain, or the recurrent common perineal nerve, whatever. If you can figure out which one of these nerves is the true pain source and block it, you have the chance to reduce pain in the knee without making major structural changes for that person.
What do you do in your clinic to identify that?
Yeah, so I can sort of surmise this from a good physical exam. I've kind of honed my skills in testing nerves to that level. We can't do the DTI, the diffusion tensor imaging, which this is sort of an example of that, because I told you we don't have the technology. We can use ultra high resolution ultrasound. I am able to do that to look for damage or abnormal nerves. Really, the best way is with certain physical exam findings and then diagnostic injections. So we can inject lidocaine, which is a short-acting agent. It's the Novocaine you get at the dentist. So we could put lidocaine and block certain nerves in the knee. And if somebody says, oh yeah, my knee pain's all gone, even when they're doing certain activities, that tells me, yes, that's a nerve. And then I can move on to doing things like peripheral nerve stimulators. These are amazing devices that if you put the electrode on any given painful nerve, you can permanently block the pain for that patient. And they can turn it on or off at will, and it's minimally invasive. It's a great option for people that don't want massive, huge surgeries. They just want one little area of pain to go away. So why do people get these surgeries? You might be asking yourself. You might be on the schedule for someone to get a joint replacement. A family member might be. Because people have pain. They have stiffness. They're limping. They don't like how their knee looks. They think it's crooked, whatever. We know that OA is affecting about 528 million people worldwide. About 23% of those are over the age of 40, okay? 60 to 85% of arthritis that is diagnosed and documented clinically is in the knee. So it's one of the most common joints to present to a physician. 66% of people with knee arthritis feel that they have the reduced ability to work, so they're not as productive as they normally are. Maybe they're not able to make as much money. Maybe going to work is very painful, and then they can't interact with their family when they get home. There's a number of reasons why people want these surgeries. Primarily, we don't have a cure for it otherwise, okay? So we don't really have a cure for arthritis. Therefore, we must manage the symptoms or completely remove the arthritis from whatever joint. There's also groupthink. Depending on where you live in the country, that culture or that area's doctors and subsequently the treatment community may believe this is the only option, that a total joint replacement is really the only thing you're going to get done. So that's groupthink. And then that means effectively you are offered no other choice. So some people, they go to see their doctor. The doctor says, yeah, you have arthritis. Come back when it's bad enough that you want me a replacement. And that, I hear that over and over again. That may be the only interaction with the medical community. And then what do? Well, you wait and you go back when it hurts so much that you can't stand it and you get a joint replacement because you've been offered no other choice. So the symptoms are real, but perhaps after that, things could be changed a little bit. Okay, so these primary indicating reasons to get a total joint replacement, be it hip, be it knee, be it ankle, shoulder, wrist, finger, whatever. Pain relief. To improve your mobility and function, you have exhausted all conservative measures, meaning non-surgical treatment plans. There's a very high success rate in our total joint literature. You trust your surgeon. You want to get back to work. You want to get back to normal life. Right now you can't because your knee hurts so much. And you want to exercise so that you can have some long-term health benefits. These are the primary indications for total joint replacements, okay? Okay, what is the truth? What actually happens? Only about half of people achieve a moderate activity level after a total joint replacement, meaning regular walking. Any actual objective increase in activity is very, very small. So remember, I told you one of the reasons we do it is to improve function and mobility. Well, it turns out that doesn't really happen. And if it does, it's only in half of people, and it's that they're walking a little bit. So it's not like you go from being a couch potato to now you're, the pickleball star in your community. The opposite is true. Most people lose function and mobility after total joint replacement, or at best achieve moderate activity levels. 50% of total hip patients achieve moderate activity, and many of them still require low-level pain medications afterwards. Many, which is the next point, about 1 out of 5 of total hips and 1 out of 3 total knee patients still require long-term pain medications 2 years after surgery. So it may be that you want to get off of your ibuprofen, your Celebrex, or God forbid your opioids, right? You get your total joint replacement. A lot of you are still going to require pain pills, even with the joint replacement. So what did you achieve? You basically just changed how your x-ray looks. Your life hasn't really changed. Okay, so remember before I told you 1 out of 3 say the knee doesn't feel normal. There's a 30 to 50% complication rate, and 20% or 1 out of 5 are dissatisfied or not happy with their knee. This is just reiterating that point. The satisfaction rate after total knee is 80 to 88%. Pain relief satisfaction goes to 72 to 86%. Function satisfaction, 70 to 84%. So it's not even close to like 90%. It's really somewhere between 70 and 88% that you're going to have satisfaction, good pain relief, good function, and so on and so forth for total hip and then the combined numbers. So the success rate is not awesome. It's good. It's just not awesome. And why is that? Why are people not happy after they get their joint replacement? You would think that is the max of our technology, state of the art. We did the surgery perfectly. The x-rays are beautiful. What is wrong with you that you don't like your total joint replacement? Well, guess what? People complain of persisting pain. Remember, I told you people stay on pain meds about 2 years later. There's limited functional mobility. Remember, I told you at best, half of people will achieve the ability to walk regularly. There's some psychological factors that can play into your post-op outcomes. We'll talk about that briefly later. More of this is being done at a younger age. And so the younger people just, I think, have more expectations of amazing results and they don't get it, so they're dissatisfied. More of us have a higher BMI, or we're bigger and heavier and obese. There's people that are in a lower socioeconomic group are shown to have less satisfaction with joint replacements for whatever reason. Maybe they just don't have the social support system to help them in their recovery. Or maybe they can't even go to physical therapy because their insurance is so terrible. There are other pain sites that are present. Maybe it really wasn't the joint that was hurting. I told you on that one slide, the massive number of reasons a knee could hurt. It's not always just the joint. And then, of course, there could have been complications, seromas, blood clot, infection, fibrosis. There's a million things that can go wrong. Loosening of the joint, low-grade occult infection that doesn't show up for like 6 or 7 years. So those are reasons that people are not happy with total joints. So I put this slide in to show you the reasons that you might indicate yourself and think you need a total joint, or you've been told you need a total joint, and then the reasons that you may not be happy after the total joint replacement, which is, again, one of the most common orthopedic surgeries in the country. Pain relief, well, we know there might be persistent pain. Improved mobility and function, well, we know you're going to have limited functional mobility. You've exhausted the conservative measures. May or may not be true depending on what you were offered. Remember, I told you sometimes you're not offered anything else or your insurance doesn't cover it. We have a really high success rate. Well, the new patient reported outcomes measures would say not so much. Trust your surgeon. Well, there might just be groupthink. Then all the surgeons in your state, this may be what they do, but if you move to the neighboring state or even the neighboring city, they might do something totally different. You want to get back to work and normal life. Well, we know a lot of people go on disability, stop working, or take a reduced work schedule. There's a massive financial hit or a wealth effect to people. And then, of course, you want long-term health benefits. Well, a lot of people after total joints are less active. They have complications. So what long-term health benefits did they achieve? None. What about knee scopes? I've kind of exhausted the arthroplasty. Let's talk about arthroscopy. Remember, arthro is just the Latin for joint. So meniscectomy, synovial debridement, trimming the articular cartilage, repairing anterior cruciate ligaments. These are all different variations of knee scopes. This is a picture of a knee scope. Basically, we put these instruments in and we use fiber optic imaging with LED lights. We're able to see in the knee. We blow it up with some fluid, and then we have a tool. So there's a viewing port and a tool port, and you can just do little things in the knee and trim and fix and whatever. 500,000 knee scopes are done a year just for meniscal pathology. So for a torn meniscus, right? You probably have had one, somebody out there watching this, or somebody in your family has. This is the primary indication in our country to do knee arthroscopy. So in 2002, there was a pivotal study that came out of the Veterans Affairs. I think it was somewhere in Texas. They did a randomized controlled sham surgery study, okay? These are not done often, but when they're done, they're very telling. In the drug world, many times you have a placebo-controlled study. In surgery, unless you do a sham surgery, there is no placebo control. So this was a placebo-controlled study on doing arthroscopy to treat arthritis. So prior to 2002, most knee scopes, the diagnosis that was used to indicate and justify the surgery was, we're going to treat your arthritis. We're going to do it minimally invasively with a scope. After this sham surgery study, which proved that it doesn't change outcomes at all, that there's no difference in pain, function, mobility, etc., for the people that had the fake surgery versus the people that had the real surgery, we saw a rapid and sustained drop in the number of knee scopes that were done for arthritis. More and more studies have shown the same. And so since 2013, there's even been a greater drop-off. What this graph is showing you, and the only thing it's showing you, is the number of knee scopes that have been done for the diagnosis of arthritis. Dropped dramatically. 413 out of 100,000 in 2007 down to 106 in 100,000 in 2018, and fewer now. So you might think, oh, we're doing less knee scopes. That's a good thing, right? Don't get too excited. What has happened is the diagnosis that we use now to do a knee scope has changed. So prior to 2002, a surgeon would say you had arthritis, the knee needs to be cleaned up, we need to go in there and trim the cartilage, trim the meniscus, do this, that, take the synovium out, get the inflammation out, you're going to do great. We're going to buy time, you won't need your total knee for X number of years. Post 2002, now your surgeon says you have a meniscal tear, we're going to go in there, we're going to clean it up, we're going to do a couple other things, we're going to buy you some time, you won't need a total joint for a few years. All that changed is now when we send in the paperwork to get approval for surgery, instead of saying for arthritis, we say for a meniscal tear, okay? Because the insurance companies are not going to pay for a knee scope that is done for arthritis. The surgery has not changed, okay? Previously, you would bill for a clean, like treating the arthritis and doing the cartilage debridement, the synovectomy, all of this stuff, and you would be able to bill for trimming the meniscus. All that changed is the insurance companies only pay for this and not this now. In other words, they pay less for a knee scope. We're doing the same number of knee scopes. It's just you can't use the word arthritis, and they're not going to pay for that. So the only thing they're going to pay for is the code for the meniscal debridement. So effectively, we're still going to do the scope if it's necessary and if we think that it's going to help people. But the insurance companies now have a reason to cut out half of the reimbursement for it. That's all that's changed. So we're actually doing the same or more number of scopes. We just say it's to trim the meniscus now rather than saying it's to treat the arthritis. Now, most meniscal tears are degenerative in nature and occur with the arthritis. So it's effectively the same whole joint systemic inflammatory process that's doing both to you, damaging the cartilage, the synovial lining, and the meniscus. We have just changed the semantics of the prior auth process to do the surgery. So the study was pivotal. It's very important, and it proved that whether you had a knee scope or not, meaning a fake surgery, your outcomes are the same. It's something you need to think about next time you're indicated for a knee surgery. And I've talked to people about this many times, telling them you're likely not going to do any better than if you didn't have surgery. But just so you know, that we're still doing a lot of knee scopes. So all that's changed is the code and then the payment, all right? The other thing that I've noticed and is starting to show out in the literature is that rather than doing a knee scope to try to give somebody a 2 to 3 year hiatus, people are just going straight to total joints now. And I've seen this with the way insurances deny knee scopes at this point. They're almost pushing me to indicate somebody for a total joint replacement versus a more temporizing, less invasive procedure. So in other words, if the insurance company gets an MRI report and the radiologist says grade 3 or severe arthritis, they will not cover a knee scope at all. They say this person needs a total joint replacement. I'm starting to see that more and more often. So just be mindful of that. But these two graphs together show you the number of knee arthroscopies for arthritis and then the number of total joints. So they're kind of inversely related, right? So maybe somebody in the middle of the graph on the left could have gotten a knee scope and maybe they would have done great because they changed other things in their life, never needed a knee replacement, but nowadays they're getting a knee replacement pretty much right off the bat. So let's say you have an MRI and it shows right there, doc, it says I have a meniscal tear, my knee hurts. Obviously that's what needs to be fixed, right, doc? Well, I will tell you, between the age of 40 and 70, in groups of people that have absolutely no knee pain whatsoever, there's a 35 to 60% rate of meniscal tears seen on MRI. And with newer MRI technology, which are better images, that rate has gone up even more. If you're in your early 40s, your odds of having, or your prior probability of having a meniscal tear is anywhere from 35 to 40%, whether or not you have pain. Age 70, 60%, more than half of you over the age of 70, whether your knee hurts or not, if you went and got an MRI today, you would have a meniscal tear. What I want to tell you is that a lot of the studies are starting to show and have shown for the past 5 to 8 years, and this is something I tell patients that come to see me, The people that have a knee scope to treat that meniscal tear seem to have more and worse arthritis sooner or later. In other words, the knee scope is doing something that is increasing the rate of progression of osteoarthritis to the point where it's worse than it would have been had you never had the surgery, with or without the same tear. So there's more osteoarthritis, particularly if root tears are treated with a scope than if they're not treated at all. The long-term damage seems to be worse after arthroscopy in general. And then at 10-year follow-up, the arthritis is definitely worse in the people that had meniscectomies or meniscal debridements versus the group that didn't. And most people did it to delay the need for a total knee arthroplasty, but they've hastened the need for a total knee arthroplasty. So this is what I try to tell my patients, and I really have unindicated many people that have been indicated by other surgeons for meniscal surgery for this reason. Now, that said, some people do actually have a tear that is flipping in and catching and doing things that are altering the biomechanics of the knee, and they do need to have a knee scope to get that trimmed. That is not, I'm not saying that not all of these surgeries are necessary. Some people have loose bodies floating around that flip in and out of the joints. So these are little nuggets of bone and cartilage that get broken off, and then they're just sort of in there, and then the pebble will go in between the femur and the tibia, and you walk on it, that hurts. So those people do need a knee scope. Some people have very inflamed synovial tissue. There's a number of reasons, but just a basic meniscal tear that may or may not be the source of your pain, you really need to think it through hard before you have surgery. And what can you do in the meantime? Physical therapy, and then other things I'm going to tell you later on how to treat these things non-surgically. This table sums it up. Randomized controlled trial, a retrospective trial, and then a longitudinal following the osteoarthritis initiative data set that I told you about. Basically, in the randomized controlled trial, so that's people that had the surgery and then a control group that didn't, similar rates of osteoarthritis progression in these two at 5 years, okay, but more joint space loss in the surgical group. So the joint got thinner. The retrospective that went 6 to 10 years, meniscectomy was linked to worse x-rays despite similar pain relief. So the non-surgical group felt as good as the surgical group, but their x-rays looked better. The longitudinal data set study at 4-year follow-up, faster joint space narrowing in the arthroscopic group and in the group that had steroid injections versus the group that had no treatment. What this tells me is that our bodies, the human system, may be smarter than surgeons. I'm just saying. So I spend a lot of time in my clinic talking people out of surgery, believe it or not. Sort of counterintuitive. Honestly, I don't know why I do it sometimes, but I feel ethically obligated to tell people the truth about these things. Now, again, I do plenty of scope. I do rotator cuff repairs. I do need whatever, but only if I think it's absolutely necessary and if they really have been offered and understand all of their non-surgical options and took advantage of them and still have problems. And honestly, most people get better. So would I have a busier surgical schedule if I just jumped straight to a scope or a joint replacement? Of course I would. But would I be a better doctor? I'm not sure. I think there's another and better way. So how can you avoid these problems that lead to the most common surgeries done in America to the tune of $100 billion? I wrote a book about this. We'll talk about it later. It's called Bone on Bone. So basically, mindset, exercise, diet, sleep, meds. This is what you need to do. Diet is hugely important. What you put in your body, you are what you eat. Your mom was not wrong. Sleep may be one of the most fundamental things that we all forget about and don't think about, but massively affects how your body functions, how your cartilage can repair itself, how your connective tissue behaves. Exercise, if your muscle mass is decreased, then your bone mass is decreased. A whole host of problems happen there. Also, exercise induces sort of increased inflammation short term, but a type of inflammation that turns on a lot of good genes and creates new proteins that help in the repair capacity. Exercise also helps reduce rates of dementia, just so you know. But exercise is one of the most fundamental, best ways to treat any arthritic condition. Historically, we were told the opposite, right? Oh, avoid that. Don't do that. Don't exercise. Sit on your couch. Rest. Take a few days. Probably the worst thing you can do. Functional recovery is where it's at. And then mindset, your attitude, whether you're an optimist or not, whether you have a positive attitude, your ability to inhibit pain signals and control the pain communication between the periphery and the central systems, hugely important. Or you can do what we normally do, which is take a bunch of pills and avoid activity. That is your traditional remedy. Remember I told you about the guy or the girl surgeon that says, oh, you're bone on bone, it's terrible arthritis. Here's a script for, I don't know, meloxicam, Celebrex, diclofenac, indomethacin, whatever. Here's your prescription. Come back when it hurts so bad. Just avoid that activity. How many of you have been told that or know somebody that's been told that? That's our traditional remedy. That's pretty easy to do. Write a script, say avoid activity, come back when it hurts really bad. You can get somebody in and out of your office in 45 seconds with that. Trying to explain diet, sleep, exercise, mindset, and then supplements you can take to help give you more of those building blocks to fight the chronic inflammation, the oxidative stress, the mitochondrial dysfunction, and the insulin resistance. That takes a lot of time and it's harder. And certainly no insurance is reimbursing for that. But some of us feel a calling to share this information. So very strong evidence for diet to treat symptoms of arthritis, okay? I love the Mediterranean diet. That is my go-to. There are very strongly or big advocates for certain other types of diets, and they would rage on this, but I like the Mediterranean diet. I think it has the largest body of evidence to support it. It's approachable, it's affordable, it's been used for thousands of years effectively. And we know that the Mediterranean diet style or diet pattern reduces systemic inflammation by 30% in people with arthritis. Now, remember I told you it was a systemic whole joint disease? If you know that just what you're eating can give you a 30% reduction in that, why wouldn't you change your diet to the Mediterranean diet? I did, and my life has gotten a lot better. They've studied this. Here's just one study. Following this diet and adhering to it for about 16 weeks, people lost 7% of their body weight and had a 25% reduction in the progression of their arthritis. This is a micronutrient-rich diet. It gives you a lot of building blocks for cartilage repair, muscle building, bone health, brain health, and it is an anti-inflammatory diet. So it's going to reduce the production of all those proteins that induce inflammation. So I love the Mediterranean diet. This should be one of your primary weapons to avoid seeing people in white coats. So I put this in here. If you remember from Top Gun, you want to invert your diet. The Western diet's on the right, the Mediterranean diet's on the left. Mediterranean, the bottom of the pyramid, the most stuff you should be eating are vegetables, fruits, and olive oil, extra virgin cold pressed. Then whole grains, not bunny bread or Wonder Bread, but like whole grain breads and pastas. Then you move on to your proteins. And then at the very, very top would be your sweets, your refined carbs, etc., your starches, your processed meats. Our diet in America is the complete opposite and has been for decades. Remember I told you arthritis has dramatically increased since 1940? Well, when did the advent of the food industry start? I've given a talk on this. It started with the Midwest with the cereal factories, and it really bloomed in like the 50s and 60s. So the food industry has kind of helped us gain this arthritic condition. Hopefully some of that's changing now, and we're following closely how the food industry regulations are going to change. Massive amounts of evidence for how important sleep is to how your body feels, your pain levels. Poor sleep is highly associated with chronic pain. Poor sleep is very much associated with progression of arthritis. Poor sleep, shift work, is actually a World Health Organization designated cancer risk. Having poor sleep is linked to almost everything bad you can think about. Why? We have to sleep because we have to fix everything and repair it and detoxify overnight. And that's the only time you can do it. And the best sleep is when you're fasted. So your gut has to be in rest mode, which means fasted. So the gut system has to be fasting, and then the body shuts down, goes into turnover time. You repair the factory, you tighten the bolts, you lubricate the joints, whatever the body needs to do so that you can do it all again the next day. Shift work is known to increase osteoarthritis, the symptoms of arthritis, joint space narrowing, the progression on radiograph. Why? Because you have far more pro-inflammatory cytokines and you have reduced clock gene expression. What is that? I've talked about this before with the circadian rhythm. If you don't have a tight wake-sleep schedule that matches your eating, sleeping schedule, there are certain genes, and most cells have these genes, not all, but most of them. Certain genes oscillate, meaning they are supposed to turn on at night and turn off during the day. And certain repair capacities depend on these genes. And then inflammatory capacity does too. So the way it's supposed to work is you're fasted at night and all of the repair genes turn on and all of the anti-inflammatory genes turn on. And then when you wake up during the day, your body doesn't spend the energy and the time and the building blocks to repair. It just spends time producing energy and allowing you to function. And then at night, again, you fix anything that went wrong during the day. That's how it's supposed to work. So what did we decide to do in America? Eat all the time and have poor sleep. And then we wonder why we feel like poo-poo. I like time-restricted eating. You've probably heard about fasting, or how it's kind of a trendy thing now to either alternate day fast for 2 days, eat for 5, do intermittent fasting, fast for a week, whatever. I don't do any of that. I just try to do time-restricted eating to match my circadian rhythm. So you don't want to eat all day like most Americans. You certainly never want a midnight snack. You want to match your sleep to wake cycle with your eat to not eat cycle. And then you can time your exercise, and some medications need to be timed too. It was a prescription delayed release steroid that was great for people with rheumatoid arthritis, because you would take it and it would not start releasing until the normal cortisol spike that you're supposed to have when you have sunlight hit your eyes, right? So that was a great drug. Of course, it wasn't covered by any insurance companies, but sometimes timing medication really matters. Timing your exercise can matter for you. It depends. Everybody's a little bit different. But what you need to know is sleep is when your body is going to fix that cartilage, fix that stiffness, make that IT band better. And also when you're going to build muscle. So let's say you worked out during the day, you ate enough protein. Well, the muscle's going to start building that night. All of this matters on sleep. So if you have poor sleep, go get a sleep study first. I've sent a bunch of people for sleep studies because that is the best way to figure out why you're not sleeping. Once you have that information, you can then fix your, whatever's going on in your life to treat that sleep. You should probably not take sleeping meds unless all else has failed, because those are not without major side effects. But I'm just telling you, sleep is hugely important. We have a whole line of supplements to help naturally induce better sleep and make sleep less fragmented theoretically, and also deeper, if you will. So it just gives you kind of the building blocks that help reduce the excitability of the nervous system to stop that, chronic thinking that happens that keeps most people awake. But when I say avoid sleeping meds, I'm talking about things like Ambien, Lunesta. All of those have a lot of side effects. If your doctor thinks they're necessary, and they are necessary, that's fine. But I'm just telling you the other options. There's a whole host of ways to improve your sleep naturally. And we've talked about that in other talks before. Exercise. So we've talked about diet, we've talked about sleep. So the D and the S of meds. Now we're on exercise. So we're going backwards. We're doing STEM. Anyway, not meds. Exercise. Resistance training has the best evidence for reduction of musculoskeletal symptoms, reduction of pain from arthritis, improvement in connective tissue disorders, okay? For a number of reasons. If you are strong, your risk of getting injured with any given sudden unexpected impact or twist is far reduced, okay? If you are strong and agile, it's even more reduced. If you're strong and agile and have good balance, your risk of getting injured is very, very low relative to somebody that's weak, can't respond quickly, and has poor balance. We know that pre-op strength predicts recovery. So the stronger you are before you go have a surgery, let's say that you actually are indicated for an actually needed surgery. If you're nice and strong and nice and flexible before that, your odds of a great recovery are much better. So it improves postoperative outcomes. There's improvements in pain and function with arthritis. So any study that you look at in the literature that looks at a group of people that exercise that have arthritis, they always do better than the groups that don't. And this study was just 24 total sessions of exercise. That's all it took. And people got a lot better and had much better function. Probably better than the numbers you would see with, let's say, I don't know, Percocet. And then exercise prevents cartilage degradation. There is a massive network of pressure sensors, shear sensors, inflammatory sensors, reactive oxygen species sensors, a million different receptors in the joints that will turn on and off repair capacity based on the stimulation they're getting. Exercise happens to stimulate all the right things and induces repair of cartilage and prevents the breakdown of cartilage. It also inhibits chronic low-grade inflammation, which I've already told you about 100 times, is one of the foundational problems of our lives. And it improves bone mass. So weightlifting, getting strong, improves your bone too, which means what? That little hard, thin layer of bone right under the cartilage is going to be healthier too, meaning less cartilage damage, less pain. So resistance training is key. Obviously, you should do some aerobic conditioning too, but I'm here to tell you, if you did the Mediterranean diet, got a good night's sleep, and started lifting some weights, probably most of your symptoms will go away. So what are good exercises? A lot of people, particularly women, don't know how to lift weights. This is a problem. It's one of the things I would love to fix. I happen to grow up playing sports, so I do know how to lift weights. I've rowed crew, I played soccer, etc. But a lot of women, especially women in an older generation than mine, where they were certainly not encouraged to be sporty at all, have no idea. So we have a whole protocol in my physical therapy department where we help people learn how to fight sarcopenia or loss of muscle, how to help people get stronger, especially women. A lot of men do have this fundamental knowledge, but still a lot of them need help and guidance as to what they should be doing for their particular body problem. Basically, in a nutshell, the best exercises to treat your arthritis and make your body feel better are multiple muscle group exercises that go through a full range of motion. So like a glute bridge where you lift your whole torso off of the ground, bend it, apex forward, and tighten up all the back muscles. You do it all at once. A plank, that's engaging your shoulder, your neck, your interscapular, your paraspinals, your glutes, your hamstrings, your calf all at once, right? Plank's a great one. Hip hinges like deadlift, Roman lift, all those kind of things. Kettlebell deadlift, farmer's carry, reverse lunges, a goblet squat where you're holding a weight here and squatting all the way down with your knees sort of abducted. All of these big whole body, multiple muscle exercises are what you need to do. Do you need to do 5 sets of 20 every day of the week of all of these? Absolutely not. If you just did a couple a day in different areas, like, one day you did some bridges and hip hinge, you waited a day, 2 days later, you did some kettlebell deadlifts and some goblet squats, whatever, break it up. But you got to do something to fight the normal 1 to 3% muscle loss that we all encounter after the age of 40. So the only way to do that is progressive overload, which is the fundamental principle behind weightlifting, resistance training, and you will get all of those benefits I just talked about. If you don't know how to do any of this, or you're nervous about getting injured, you go see a physical therapist or a chiropractor, or hire a personal trainer, or whatever you can do. There are many professionals out there that would bend over backwards to try to help you learn how to do this. Mindset, now we're back to M. So we did SDE, now we're on M of the meds protocol, which is in bone on bone. Mindset turns out to be the most important factor for outcomes in all of our research studies where they actually looked at it. The whole body of literature prior to, let's say, the past 3 to 5 years in orthopedics has ignored mental health, ignored mindset. But it turns out now that we're doing studies where we look at pre-operative mental health and post-operative outcomes, we now know that it is more important than the skill of the surgeon. It's more important than the weight of the patient. It's more important than whether they smoke or not. It's more important than if they were taking narcotics or not. Mindset is key to your functional and pain outcomes of any given procedure, which means also, and this is shown in many studies too, that it is important for before you have surgery. So the people with the better mindsets, quote unquote, or the ones with the mindsets that inhibit pain, promote exercise, give a positive attitude, and decrease stress mentally, those people tend to not have as much pain and have better function, better performance, better work, better sleep, everything. Wait, we went back to diet? Okay. The evidence. What is the evidence of mindset? Optimism is shown with 30% lower pain catastrophizing. So what is pain catastrophizing? These are the people that say, my pain is never going to get better. This pain is the worst pain ever. This pain is ruining my life. There's no future for me except for this pain. So everything is catastrophic in their thinking about pain. 30% of that drops in optimists. So just training your brain to be more optimistic reduces pain catastrophizing, which means you have better outcomes from any given treatment. And 20% less actual pain. So not only are you thinking about it less catastrophically, but you actually have less pain. Why? Because the brain has a capacity to amplify or turn down pain signals. So you can go to 11 or you can go to 1, and your brain controls all of that. Active coping is really another mental or mental health or mindset paradigm that really helps. So avoiding things does not help your pain and certainly never improves function. I've told you that we're part of the problem. Many doctors have told people and still tell people to avoid activity. Probably the worst thing you can do. Actively coping and actively facing the problem and dealing with it, 20% reduction in pain. Functional MRIs of optimists have been done. These are MRI studies where they look at certain brain centers to see what turns on and what turns off in the face of certain stimuli. Optimistic people, so people that test high on optimism scale in certain surveys, have more activation in the anterior cingulate cortex and the prefrontal cortex. What does that mean? Those are the parts of the brain that control pain perception. So the functional MRIs prove that people that are optimists have better ability to turn down their pain signals. So this is a busy slide too, and all I'm going to tell you here, this is a big, massive database study that was done with machine learning using Bayesian statistics, which looks at conditional and changing probabilities. What they looked at was the actual pain and perceived pain felt by people in the face of certain stimuli. And they found that if your bias is good, meaning that your expectation is that you can handle the pain, it's not going to be much pain, it's no biggie, in the setting of a certain stimuli that is expected to give this much actual pain, you will have this much. So if you think that you're going to have less pain, you will have less pain. That's what this study showed, and the opposite was true. So if you thought you would have that much pain or worse, you thought that it would get worse with the stimuli, that is exactly what was going to happen. And they matched this to control groups as well. So this is what I'm talking about. If you can train your brain to start thinking more positively and to understand that you do actually have the power within yourself and within your own skull to control things, then you will. It's sort of a self-fulfilling prophecy either way. Okay, so what works to treat these conditions to try to prevent a metal and plastic sandwich replacement of your joint, and what doesn't work? We know diet has excellent evidence behind it and works great. We know exercise has excellent evidence behind it, works great. We know sleep has excellent evidence and works great. Mindset, excellent evidence, works great. More importantly, these don't have side effects, and they're good for everything else. They prevent dementia, they prolong life, they reduce cancer risk, they reduce diabetes risk, reduce obesity risk. So that group on the left, diet, exercise, sleep, mindset, awesome. So what do we do in the medical community? We prescribe medications. We tell people to avoid activity. We never discuss weight or diet. We offer surgery and we offer steroids. So I have sort of tried to move from that, which is how I was trained and what I was taught in med school and residency, to this side. So from the heavy medication, surgery, injection side to more of the meds, mindset, exercise, diet, sleep side. That left column, diet, exercise, sleep, mindset, that is how you're going to treat your arthritis, your connective tissue disorder, and your pain naturally with the same or better outcomes than anything on the right column. So medications have many side effects, limited efficacy, and short-term benefit only, and they don't induce any healing. If I tell someone to take tart cherry extract, which has anthocyanins, which reduce the activity of the COX-1 and 2 enzyme, okay? And they also act as a strong antioxidant and also help the body's mitochondria function better. There are almost no reported, if any, side effects of tart cherry extract. It's basically like eating tart cherries. They're going to get the same pain relief result as if they took a COX-1 or 2 inhibitor, like let's say Celebrex or ibuprofen or something. But here's the rub. The NSAIDs, the non-steroidal anti-inflammatory drugs that we prescribe a lot and that you take a lot of, have cardiac side effects, GI bleed side effects, GI dysfunction side effects, and kidney damage side effects. So they have a whole host of problems with them. Sure, they work great and they mask pain. I prescribe them a lot, but I try to get people to minimize how often they take it and the dose they take. How do you do that? You give them the other natural ways to reduce inflammation, natural ways to reduce oxidation through diet, sleep, exercise, meds, and then some supplements. So my preference is usually Celebrex, or now it's Celecoxib is a generic, because it seems to have the lowest GI, cardiac, and kidney risk. Everybody's different. Some people with sulfa allergy cannot take Celebrex because there's a cross-reactivity. The other thing I'll tell you about non-steroidals is they block that first phase of healing. So over time, they actually may worsen your inflammation and arthritis because they're never letting your body's immune system function the way it's supposed to for healing any microscopic damage because you've turned it off. So if you're on these meds, that's fine. They're totally within the standard of care. Many of them are over the counter now. Just be judicious in how often you take them and the dose you're taking. And obviously talk to your physician about any time you want to add a supplement to your regimen. Activity avoidance, one of the primary ways we treat people that hurt, right? Oh, stop doing that. 14 million people with arthritis are physically inactive, despite all of the evidence that shows that physical activity improves the situation overall. Because of that, you lose many quality years of your life because you're inactive. And physical inactivity was actually named by the World Health Organization as a global pandemic in 2012. The human body and the human brain was meant to be used, meaning in motion. We were not meant to sit and stare at tiny screens all day. We're meant to use our body and lift things and move at a rapid pace and reach for things and go around like you're supposed to do things. Most of us don't. It is now a global pandemic. And guess what? More arthritis happens in that case. They've looked at the joints, the weight-bearing joints, like the knees and the hips of people with paralysis after spinal cord injury, and they have thinning joint spaces, joint space narrowing in their weight-bearing joints, not wear and tear once again. So you have somebody that literally never loads their knee joint, the knee joint thins out and gets arthritic. So comparison, let's compare the treatment protocols, okay? Control your mindset or get better at your mindset, cognitive behavioral therapy, mindfulness, yoga, meditation, whatever. 25 to 30% reduction in pain. Improve your diet to Mediterranean, ideally, 30% reduction in pain, improve cartilage health. Start exercising, especially resistance training, 30% reduction in pain, reduce your overall inflammation, improve your bone health, reduce cognitive decline. Sleep, 25% reduction in pain, better cartilage repair capacity, better cartilage health. Compare that with no side effects and all of those side benefits to medication. 30% reduction in pain in only 50% of people with many side effects. Inactivity, don't do that, it hurts, stop doing that. No reduction in pain, more pain and more deterioration over time. Most professional athletes, when they get injured now, engage in what's called functional recovery. So they don't stop moving at all. They may just go down in load and increase frequency. There's different ways to modify it. But like, let's say you're an archer and you injured your shoulder doing this. They would actually find ways to do this in a less stressful manner so that they're still moving and still doing things. That is functional recovery. When I do ankle ligament repair surgery now, I get people weight bearing within a week because functional recovery makes the body better. I also do functional recovery beforehand so that they can effectively avoid that surgery. Most of my ankle ligament surgery repair that I do nowadays is on people that never got early PT when they were injured somewhere else and treated elsewhere. So they end up with long-term functional problems that then I have to address. If you have an ankle sprain and you can get into physical therapy very quickly and start a functional recovery protocol, you probably will never need surgery. Shoulder. Let's get to that. Probably somebody out there is indicated for a shoulder scope, or you have a rotator cuff tear. There it is on the MRI, doc. I absolutely have to have shoulder surgery. 400 to 500,000 of these are done a year, as a matter of fact. Most are indicated for rotator cuff pathology. This is a picture of a rotator cuff repair. Those 2 tubes coming in, that's the scope. That red thing is the muscle. The yellow circles are the suture anchors that have the suture connected to them, and then you do this bridge, tack it down, repair the torn rotator cuff. Excuse me. The rates of this surgery, again, even with all of our inactivity and everything else I told you, have been increasing 10% a year over the past 10 years. That's 7.2 years to double the rate. So it's obviously doubled, and it's just going to keep doubling how many of these we do. They're indicated typically after an MRI shows a rotator cuff tear. Well, what is the prior probability of having a rotator cuff tear? Or what is your prior, if you're thinking about it in a statistical manner? With or without pain, meaning your shoulder hurts or your shoulder doesn't hurt, and you go get an MRI, if you're between 40 and 60, a third of you are going to have a rotator cuff tear. If you're between 60 and 70, 30 to 40%, and if you're over 70, almost 60% of you will have a rotator cuff tear, whether your shoulder hurts or not. That is your prior baseline prevalence of rotator cuff pathology. Or I should say rotator cuff tears on MRI. Pathology is a pejorative term that indicates something's wrong. Sometimes rotator cuff tears just are. They're neither good nor bad. So again, what would make me indicate you for a shoulder scope to treat your rotator cuff? You have shoulder pain, you're weak, you have trouble with ADLs like reaching for the coffee cup or reaching behind in the car. And of course, we have an MRI with a positive finding. The goal of that surgery is to reduce your pain and improve your function so you don't hurt anymore. You can reach for that coffee cup, you can reach behind, you do whatever you have to do at work without pain and weakness. So that's why we do the surgery, and that's a purported goal of surgery. So do you really need the surgery? Most surgeons will say, heck yeah, you need the surgery. But I want you to kind of just sort of sit back and think about it a little bit harder than that. There's actually a great series of studies, and this is out of a European group, a consortium of multiple universities called the MOON group. So the Multicenter Orthopedic Outcomes Network. And they've been following different sports-related injuries over time and comparing in a very good way, prospective and randomized with controls. Treatment with surgery versus not surgery, what really are the outcomes? So in their work on atraumatic full thickness rotator cuff tears, so you go to the MRI, oh, you have a tear in your supraspinatus tendon and it's retracted a centimeter. That's why your shoulder hurts. We need to get in there and fix that. Those are the people that this group looked at. Prospective randomized. Most great studies are prospective. Most retrospective studies are considered poor or at best sort of okay evidence. Prospective studies pick up much more in a much more fine detail. They looked at a physical therapy protocol as a treatment versus surgery as a treatment. If you have a full thickness rotator cuff tear, what this study found, this prospective randomized multi-center large number of patient study, so a great study, found 75% of you avoided surgery at the 2-year point, and then 70% of you were pain-free, functioning fine, doing just as good as a surgical group at the 10-year point without surgery. Meaning only 28 to 30% of people ever got indicated for or needed surgery. So physical therapy is a great, in fact, should be the mandatory first treatment option. Now, they have a certain protocol and it was very active recovery, very active functional recovery. I'm not talking about the physical therapy where they put an ultrasound, they put a wet, warm compress, and they like rub some pain cream in. This is not passive physical therapy. This is functional recovery. Function improved, pain got better, stable improvement for a decade without surgery. How about that? in almost 3/4 of people. So the predictors of who would end up being in that 28 to 30% of people that needed surgery in that 10-year window, poor mindset. That was one of the number one indicators. So people that had low expectations of benefit from physical therapy, they did have low benefit from physical therapy. So you really kind of have to believe in the treatment. Now, they believed in surgery. So that's what they wanted. That's what they got. So that's what they were calling poor mindset in this Moon Group study. People with workers' compensation status tended to have more surgery than people outside of that group. They did find that people with higher activities levels seem to end up having surgery more often and people having later surgery. But basically, in a nutshell, you need to know if you have a full thickness rotator cuff tear, you have a family member that does, and you have shoulder pain, you have a massively good chance of doing great with just physical therapy. And that goes for full thickness and partial thickness tears. And you may say, well, I have a tear, but my latest MRI showed the tear got bigger. Doesn't matter. They even looked at that. Tear progression did not correlate and does not correlate with the need for surgery. But 27% of people did need shoulder surgery at some point. So I'm not saying it's not wholly never needed. It will be needed for some of you. But I want you to strongly consider the MEDS protocol, mindset, exercise, diet, sleep, and the exercise paradigm is going to include structured functional physical therapy. What about ACL? I tore my ACL. Obviously, I have to get that fixed. I mean, every football player is getting their ACL fixed 2 or 3 times a year, right? Well, what happens if you have an ACL tear after the age of 40 and you're not a high-level pivoting athlete, okay? The Moon Group followed these people for 10 years. And noted that the people that had the surgery seemed to maintain their quality of life, yes, but their activity declined over time, just the same as the non-surgical group, and less function returned to the over 40 group than the under 40 group. So like if you tear your ACL and you're a 20-year-old college athlete and you get your ACL repaired, your functional recovery is going to be expected to be better than if I tore my ACL and got it repaired. It's kind of like a duh result, right? But a lot of science is that. We prove that the duh is in fact correct. So if you're a young, healthy 20-year-old kid, you're obviously gonna have a better outcome than a 40-year-old that's been living the American lifestyle for 40 years. Other injuries at the same time as the anterior cruciate ligament tear, the ACL tear, and revision ACL surgery predicted bad outcomes. A lot of ACL surgery doesn't go well and people have to have another repair or the graft ruptures. There's a massive body of literature just on what type of graft you should use because so many of them fail. So I don't want you to go into an ACL repair lightly either, even though you would think logically it's a major ligament in my knee and it tore. Obviously, I should get that fixed. The Moon Group has shown, no, that's not obvious. So let's say you're over 40 and you tore your ACL, let's say you were skiing. And you've had persistent instability, your knee just feels loose or unstable. Can you go back a slide? Sorry. Okay. You had persistent instability and you have very high activity demands. Okay. So you're thinking to yourself, I tennis every weekend. I tore my ACL. I have to have it fixed. Fix it now, doc. What's wrong with you? Well, in this Moon Group where they looked at people, again, prospective randomized, very high quality evidence, 37% of the non-operative patients crossed to the surgery group in 2 years. So we'll round up to 40. So 60% of you are never going to need surgery and you're going to do great. The study did show that delayed surgery leads to more meniscal tears. And I can tell you this is what we are taught and what's on all orthopedic residency and training exams. If you have an ACL tear and you don't fix it, the odds of getting a meniscal tear later go up. And if you have meniscal tears and an ACL that's not fixed, you have instability and you'll have more wear and tear, right? And you'll have more arthritis. That is the theoretical underpinning of this whole industry. So the thought is that you should make the decision for surgery, you should pull the trigger very quickly. Okay. 63% of people that tore their ACL over the age of 40 were successfully treated without surgery in the Moon Group's prospective randomized controlled long-term study. Physical therapy adherence impacted the outcomes massively. So in that 37% of people that ended up wanting or needing surgery, a lot of them did not do the PT they were supposed to do, or did not follow the protocol, or didn't engage in it with their full mindset. They weren't positive about it. Again, the reason we always say to fix it is to prevent meniscal tears, because we don't want to progress arthritis. And the reason we care about that is we don't want people to need total joint replacements, right? I put these two slides in here to show you a 99-year-old playing pickleball and then a 95-year-old playing pickleball. So presumably they've been wearing and tearing their knees for 95 years, right? May or may not have meniscal tears, may or may not have ACL tear, may or may not have rotator cuff tear. Doesn't matter. They're out there moving, they're exercising, and they are that high functioning because they are that high functioning. The people that let themselves get complacent and sit around and say, oh, I can't do that, I'm too old. That's when you get too old. So all of our problems of age don't happen because of age. Age happens because we let it happen. So be more like these ladies here and move and get out there and do stuff with or without these injuries. You just need some guided treatment, some guided exercise protocols. So remember, I just told you the ACLs are fixed to prevent meniscal tears, prevent arthritis, prevent total knees, right? That's why we do it. But what's the rate of meniscal tears over 40 anyway, with or without pain? We talked about that in the knee arthroscopy section of this talk. We often see these meniscal tears on MRI with or without an ACL tear, with or without pain. The rates of asymptomatic meniscal tears, meaning meniscal tears in people that have no knee pain, no history of injury, 30 to 40% in the 40 to 60-year-old age group, which is what we're primarily talking about here. 30 to 40% up to 69, and then about 60%, 70. So again, our prior probability, our prevalence, baseline prevalence of having a meniscal tear is pretty darn high, with or without an ACL tear. And the ACL ligament reconstruction surgeries are done to prevent meniscal tears. But if your prior baseline prevalence with an ACL tear, you're over 40, we know from knee arthroscopy studies that 65% are going to have a meniscal tear, but 20% of those managed non-operatively needed a meniscectomy within 2 years. That's from the Moon Group study, okay? So you've got 65% of your over 40 group, they tore their ACL, and we know they tore their meniscus at the same time. We see it on the MRI. Of the group that was non-surgical, only 20% of that group moved on to the surgical group at 2 years. And those patients said it was because they felt a lack of stability and they felt like it caused more pain. So the surgeon interpretation is the lack of stability caused meniscal tearing, indicating them for surgery. So it's 20% of 65%, right? So if 65% of people over 40 that tear their ACL probably also have a meniscal tear from that injury, 20% of them are going to need surgery within 2 years. That is 13%. So 13% of people with an ACL tear and a meniscal tear might want or need surgery within 2 years. To me, that means you should try physical therapy first. I don't know about you. But if there's a 13% chance that if I tore my ACL and I had a meniscal tear, I would want or need surgery, but I could wait it out 2 years, why wouldn't we try a good physical therapy program before that? And then, oh, by the way, why don't we change our diet, add in some good micronutrient supplements, get some good sleep, etc. I'm just saying, a lot of our surgeries, there is another way. Not that you might not need it, but there is another way. So 13% ACL tears over 40 will have surgery. They're fixed to prevent the instability, to prevent the arthritic progression. But more than 40% of those of us over 40 already have a meniscal tear. What do we do? I'm just going to reiterate the knowledge. This is the way. Strength. We're back to exercise, resistance training. What do we do in rehab for athletes that tear their ACL? Quad strength, hamstring flexibility, calf flexibility, calf strength, hip strength. The hip plays a massive role in your knee biomechanics, okay? Quad strength is hugely important. If you can get up to 90% of your leg's strength after an injury like an ACL tear, then you're almost back to normal and your need for surgery is going to drop even more. There is a significant reduction, even with an ACL tear, of tearing the meniscus if your quads are strong. Why? Because now you've got all that dynamic stability added. The muscle connected to the connective tissue, connected to the joint capsule. All of the nerves are firing properly to give your brain the information it needs to adjust what muscles fire and don't fire with any given twist and turn when you're playing pickleball or when you're playing tennis or when you're playing soccer. Getting back strength does more than just make you strong. It gets the way the knee responds to movement back better. Your injury rate is dropped. Remember at the very beginning with exercise, I told you your rate of injury drops dramatically. This is why. Core strength, hip strength, also massively important, will alter the alignment of the legs and again, how you handle any given twist or impact. So this is the way that you can treat your ACL tear without surgery. Quad strength, hamstring strength. You got to get into a good program of some sort to rehab it or prehab it and hope you're in the, what is the opposite of 13%? 87% that won't need surgery. So the Norwegian registry, which is all the surgeons in Norway put all their data in. Remember, it's a nationalized system there, so they can track data better than we can. 2022, they showed that ACL reconstructive surgery does not halt the progression of arthritis. And remember, our baseline total knee replacement risk in your 40s is a 0.1 to 0.2% risk every year, compounding. 50s, it goes up, and your 60s, it goes up. The risk for total knee replacement with an ACL reconstruction surgery in the 40s, you're up to 0.46 to 0.97. Your risk of a total knee replacement without an ACL reconstructive surgery will go to 5 to 10% at 10 to 15 years out. So the relative risk looks massively different, but the absolute risk is not that much more. But also remember the groupthink problem. So if your surgeon knows you have an ACL tear and you start showing up with some knee pain, and there's a little bit of arthritis on the x-ray, they are going to indicate you for a total joint replacement. As opposed to if you went and saw somebody in, let's say, the Moon group, they might have a whole different way of thinking about this. So per 10,000 people, the total knee replacement rates with an ACL reconstruction after an ACL tear is going to be 180 per 10,000 people in the 40 to 49 group, jumping up to 310 per 10,000 in the 60 to 69-year-old group, okay? That's the rate of knee replacement with a reconstruction. The rates without the reconstruction, 40 to 49 goes to 200 per 10,000. In the 60 to 69, it goes to 300 per 10,000. So what is the delta there? It's 20 people per 10,000 and 10 people per 10,000. That's your absolute increased risk rate of needing a total knee replacement with and without an ACL joint or ACL ligament reconstruction. And remember, that's the reason we say everybody needs them reconstructed. So 20 people out of 10,000, if you're 40 to 49, that's the difference. 20 people if you're 50 to 59, 10 people if you're over 60. 35% risk of chronic pain in your knee after an ACL ligament reconstruction. And what is the average out-of-pocket cost of an ACL reconstruction? $4,000 to $5,000 out of pocket. Remember, deductible plus your coinsurance. 6 to 12 months for recovery. Massive numbers of days missed of work. If you have a desk job, almost a month. So you're not making money for a month. If you have a labor job, up to 3 months. Some people full duties delayed up to a year. Massive number of lost wages. The wealth effect is very negative to have these types of surgery, estimated at $15,000 to $30,000 less that you could be investing that would compound annually. So it's probably even bigger than that. So whenever you think about these big surgeries, you've got to think about the wealth effect in addition to what it's going to do to you, in addition to the potential outcomes and complications. And I try to counsel people on this all the time. Obviously, this is what, an hour and a half talk. I can't do this for everybody all day in clinic. That's why I do this for free for the community at large. And I'm sure there's about 1 billion orthopedic surgeons out there that will say this entire talk is totally wrong and I'm crazy. And that's fine. I'm just giving you an alternative viewpoint. So should you have this surgery? That's like saying, should you do a flyby of the tower? Negative, Houston, the pattern is full. It's cool, it's fun, but should you do it? You're probably going to get in trouble if you do it. So super cool, but maybe rethink it. Now, that said, some people really do need to get these things fixed. If you are a high level pivoting athlete, you're young and healthy, get it fixed. But I will tell you, if I tore my ACL, I would not have that surgery. I would rehab the poo-poo out of my knee and do everything I could to treat it naturally. We've talked about the placebo effect of surgery briefly when I told you about that sham surgery study. That was Dr. Mosley in 2002. Same results as real surgery for up to 50% of people. So surgery is a very good placebo. 30% of people that have surgery should have a good outcome no matter what because of the placebo effect. Calms in 2009 did sham vertebroplasty for osteoporotic fractures. Up to 60% of people in the sham group had the same results as people in the non-sham group. And in all other sham surgery results, it's 20 to 60% response rate. So somewhere in the middle of that 20 to 60% is your general placebo effect of surgery, which is somewhere around 30%. So just remember that too when you go have surgery, that there is a very powerful placebo effect. And this is because endorphins are released with expectations. I showed you that Bayesian statistic model where they looked at pain expectations. If you expect the surgery to work, which most people do, it probably will, because you're going to release endorphins. Dopamine is going to come out. You can have better serotonin levels. Your prefrontal cortex has been primed with your expectations. Your anterior cingulate cortex is working on pain modification. Your insula in your brain is processing the pain to your benefit. The autonomic nerve system is going to suppress the sympathetic system with the placebo effect. The immune system actually changes and you produce fewer inflammatory markers. This has been shown. They've looked at biomarkers with placebos. Conditioning and learning, if you don't have learned helplessness, you're going to do better. And then there's social aspects and cultural aspects where some people really just have been taught to believe that surgery is the way. I'm teaching you a different way. I do surgery. I love surgery. I think surgery works for a lot of indications. But in many cases, there is a non-surgical option that should be considered strongly. And we talked about those. And that's the book, and I write about it extensively and give you lots of literature you can go read for yourself. The MEDS protocol: mindset, exercise, diet, sleep. Hugely important. I've given you a brief synopsis of the evidence behind it. And I've talked about the very commonly done joint replacement surgeries, scopes, rotator cuff repairs, ACL repairs, and what the data really shows. What are the indications? What are the real outcomes? And now I'm offering you a different way to handle these problems, maybe without these very expensive, very time-consuming surgeries that can dramatically affect your wealth. So supplements. I love supplements because I love the Mediterranean diet, but I can't get everything I'm supposed to because I just don't have time. You're supposed to eat 9 servings of fruits and vegetables every day. All of your meat should be grass-fed, grass-finished. You should never eat anything processed, et cetera, et cetera. It's really hard to achieve that sustained on a daily basis. So to make sure that I get the building blocks I need for my cartilage to repair itself and to have the proper mindset and to reduce my overall inflammation and damage from free radicals or unpaired electrons, I supplement. Now, because of this, I also have started a company that sells supplements that I know are third-party tested, made in America, safe and effective, in terms of the literature that's been done on supplements so far and the basic science findings behind them. And the reason I do this is to give building blocks for repair, to reduce inflammation, reduce oxidative stress, and to improve my collagen's elasticity and function and that of my patients, friends, and family. So I know there are ways to do this naturally, and the supplements just sort of support this. Here's another amazing diffusion tensor imaging of cartilage and nerves inside of an ear and bone health, bone structure, just showing you what's coming. I cannot wait till I can offer this and look at these studies to really know if what we're doing is helping the microarchitecture. So provide those building blocks for your repair. For collagen specifically, if you want to get your cartilage healthy, your bone healthy, the fascia and the tendons and the ligaments to make your bone, your muscles stronger, you need the building blocks for that. So B complex vitamins are very important for nerve health for sure, but there's also a coenzyme that's B dependent for DNA construction and repair. So not only do you need B vitamins to carry the iron around your body, so we've all heard of B deficiency anemia, and to have good nerve function, so people with B12 deficiency have neuropathy, but you need it for better muscle function, protein building, and DNA construction and repair, so B complex. Vitamin C. Vitamin C is not only a massively powerful antioxidant, meaning it will capture those free unpaired electrons and keep them from damaging your tissues, but vitamin C is a vital cofactor for one of the primary enzymatic reactions in the formation of collagen. Collagen is a triple helix braided structure. You can see it on the bottom of this picture. But what's keeping all of those braids from just slipping on each other and falling apart are crosslinks. These crosslinks are at strategic positions and of a strategic strength that allow movement of the collagen. Vitamin C is vital to that. So I don't know if any of you out there have read Mutiny on the Bounty or heard of scurvy. The reason they went in search of breadfruit, the Navy in Mutiny on the Bounty, was to prevent scurvy in soldiers. What is scurvy? When you spontaneously bleed from everywhere. Why? Because your collagen is so deficient of vitamin C, it has no ability to maintain any structural normalcy, and blood just goes everywhere. That is scurvy. That is true C deficiency. But for optimal function of your connective tissue, you need even better than that, obviously. So vitamin C is a supplement you should take. Zinc, it's a mineral, but it's a cofactor to hundreds of vital chemical reactions in your body, to include those involved in cartilage repair, etc. Magnesium, another mineral, massively important for bone mineralization, also a cofactor in hundreds of reactions. Minerals are often cofactors in reactions because they can easily move electrons around, just so you know. Calcium, very important for how the nerves talk to each other, how the brain communicates, also obviously for bone mineralization. So these are just some basic stack vitamins that should be taken to help your collagen and your cartilage repair itself. How do you reduce your inflammation? Well, we know that turmeric or curcuminoids, this is from the turmeric root, which you would think of as like curry. Okay, it's like that yellow spice. Shown in thousands of studies to reduce inflammation and help mitochondria function better. Ginger, same thing. Ginger's been studied in arthritis specifically and very, very powerful. Ginger has a great side benefit of reducing irritation in the GI system. Resveratrol, the so-called French paradox, or what is found in red wine, it's actually just found in like dark-skinned, certain dark-skinned fruits. It's also found in Japanese knotweed. So there's a particular Japanese tea that is very high levels of this. Resveratrol has been shown to upregulate the proteins that allow DNA to repair itself and also to reduce inflammation. So resveratrol is one of our so-called longevity molecules that a lot of the people in the anti-aging community take. I take resveratrol every day. Turmeric and ginger are in our joint health multi, and they have been studied extensively in the reduction of certain biomarkers of inflammation and also in helping the mitochondria function at a higher level. Tart cherry extract, we talked about briefly earlier, the anthocyanins in tart cherry can down-regulate COX-1 and COX-2 enzymes, but also help the NFKB system, which is a gene translation system. So this is a protein that goes in and tells your nucleus to either make inflammation or don't do it. Tart cherry triggers it where it doesn't do it. So it reduces inflammation in a different pathway that is far less damaging with far fewer side effects than all of our synthetic anti-inflammatories. And then I really can't ever say enough about omega-3. One of the reasons the Mediterranean diet has been so successful traditionally is it used to be very, very high in omega-3s because a lot of seafood was eaten. Now, seafood's very expensive. Wild-caught seafood that has been tested for like poison and stuff, even more expensive. So I get my omega-3s through a supplement because I can get the doses I want and the doses I need. And again, our supplements are third-party tested. They're from good bodies of water with lower pollution levels. And we have a good ratio of DHA to EPA, which is what you want. DHA supports cellular membranes and the structure of neurons and things in your brain, and also the connective tissue cellular membranes. And if you have a certain amount of omega-3s in your cells, you're a little bit more flexible. So I tell all of my arthritic patients who have pain and stiffness, not only the Joint Health Multi and Tart Cherry, but they should also consider omega-3s and resveratrol if they're not eating a perfect Mediterranean diet, which honestly, anybody that shows up in an orthopedic surgeon's office usually isn't. Not saying all of you aren't, some of you are. So these are my stacked supplements that I take to help supplement my diet, which I try to make good, but isn't perfect. How do you reduce oxidative stress? Believe it or not, D3. Not only is D3 necessary for bone mineralization, there's a D3 receptor on almost every cell in the body. So nothing works right if you're D deficient, particularly your immune system. Why does that matter? Well, if you don't want to get sick, it matters. But honestly, the immune system is what is repairing your cartilage at night while you're asleep. That is the system that does it. We should all have a perfect immune system if we want to avoid chronic disease. Tart cherry extract we talked about, also a very strong antioxidant, not just an anti-inflammatory. All of the polyglycans found in various species of mushrooms like lion's mane, cordyceps, reishi, all of these are not only great for the brain, they're also great oxidative stress reducers. They can capture that free electron. CoQ10. Some of you out there are on statins to reduce your cholesterol, which you should be because that's the #1 killer in our country, heart disease. But statins, by definition, halt the pathway that also produces CoQ10. CoQ10 is necessary in the electron transport chain, and it pulls free electrons out of tissue. So if you have less CoQ10, you have lower bioenergetics, particularly in muscle tissue, and most people have muscle pain, brain fog, different little side effects and symptoms of their statins. I would say rather than go off of your statin, you should try to add in a CoQ10. We have a very convenient gummy that allows you to do that. It gives you about 150 milligrams a day, which is the studied level that really helps. You have to take your statin daily, so you would need to take your CoQ10 daily as well. But remember, every time you reduce your LDL receptor, you're also reducing your CoQ10 molecules, and your electron transport chain, meaning your mitochondria, isn't going to work as well. So consider that too, to not only reduce oxidative stress, but to improve your mitochondrial function. NMN. There's a big trend out there in social media right now for everybody to go get these NAD infusions. Well, that takes 4 hours, is massively expensive, and has a relatively great effect, but not sustained. I take NMN instead. NMN daily is converted in one enzymatic step in your body to NAD. So you can get your NAD levels up just with an oral NMN. It's just the precursor to it. Why do you care about your NAD levels? It upregulates the proteins that repair DNA, just like resveratrol does. But it's also the mandatory electron transport within the electron transport chain. And it brings the electrons from the food, from the Krebs cycle, to the mitochondria. If your NAD levels are depleted, then your mitochondria cannot function at the levels it was meant to. People that have some pain that I think might have a more neural component than not, like the arthritis pain is really from nerve irritation, I'll often add in ALA and PEA. PEA is in the same family as all of your endocannabinoids, like anandamide. So those of you that are taking CBD or medical marijuana, you're working on the endocannabinoid system. PEA is a molecule we make all day, every day in our bodies. We're just not making enough of it. It reduces inflammation on the peripheral nerve ending. So it's great for nerve-based pain. So all of my people with any kind of central sensitization syndrome, any kind of neuropathy, any radiculopathy, any nerve injury, PEA and alpha lipoic acid, which is a great antioxidant that can actually penetrate the fatty insulating layer of most axons. That's a good combo to add. So ALA and PEA. You already talked about vitamin C. I already told you what a great antioxidant it is. This is why all of your beauty, your skin conditioners that prevent wrinkles have vitamin C, because it's detoxifying the free radicals that the UV sun rays, the photons from the sun create when they hit your skin. So what about the stiff people? We briefly touched over this, but there's one more thing you need to think about. Omega-3 is going to reduce inflammation and improve the cellular membrane flexibility, which then, amplified will improve your collagen flexibility. So you need omega-3 for a few reasons. Vitamin C, we talked about the collagen cross-linking, and it detoxifies the connective tissue by pulling out those free electrons. But you also need to consider the amino acids that are part of collagen. I know there's a big trend out there for bone broth and bone marrow and all that. which is good. You should. I make my own chicken soup stock from chicken bones, from grass-fed organic chickens, of course, if you can do it. That aside, if you can't get a perfect diet and get enough collagen in that way, I take glycine. Glycine is every third amino acid in normal collagen is glycine, the others being lysine and proline. So if you can give your body all the glycine it needs, it's the triple helix is going to form better. And you need that vitamin C to allow the crosslinks to happen. So glycine, vitamin C, and omega-3 for the people who are predominantly stiff versus painful is usually what I recommend. Plus stretching, obviously, and still resistance training. So the book is out there that goes over all of this in detail. It can be read in sections, each section broken up, and gives you some good hints and whatnot. I did it to sort of allow this to happen on a more ongoing, continual basis where you can refer back. So you don't have to keep going to an office of a doctor and paying a copay to hear this. And then the supplements we sort of already talked about in great detail, but we can talk about them again if you would like. A lot of people ask me, where can I get them? Or what do I do when I do have these arthritic conditions? Again, that bottom left with the blue and the red is showing you sort of a SPECT CT scan. I order these a lot to show me if there's really an active point of arthritis within the knee joint itself, or is the pain really from outside the knee? So that's a trick I use. It's a little bit more informative than MRIs to tell me if there's bone turnover in a knee. That aside, let's say I have somebody that I do think their pain is from arthritis and they do need to tackle that pain. I usually start them with the Joint Health Multi in the morning because it has those curcuminoids and the ginger like we talked about. It also has a little bit of PEA and some black pepper. Take that in the morning, and I usually tell people tart cherry extract at night. Why? Because most of those pigmented fruits that will give you the flavonoids and the polyphenols or the plant chemicals that reduce inflammation also have melatonin. The last thing you want to do is take melatonin in the morning. You really only want that in the evening. So naturally, during the day, your cortisol should spike in the morning, then drop. And during the day, your melatonin should spike in the evening and drop. So it should be like this. If you take melatonin in the morning, you're going to screw that up. So Joint Health Multi in the morning, tart cherry at night. The omega-3s, AM or PM, whatever works best for you. Hint, when you open omega-3s, however you get it, put it in the fridge because it is fish oil. Fish oil can go rancid. So I put it in the fridge. The fridge is dark and cold. You don't want UV rays hitting it. Ours comes in a dark container for that reason, to block the UV rays. And then, of course, the B complex, which is really mandatory for all situations in the body. But a lot of people forget about it when they're trying to treat their pain. So connective tissue pain or general immune health. My very first supplement that I came up with to help my patients recover from surgery, it was a connective tissue multi because it has calcium, magnesium, zinc, C, and then you can get one with CBD or with PEA. Both are going to go to the endocannabinoid system, right? But some people don't want CBD, so they get the one with PEA. They're both equally effective in reducing pain a little bit, but for the basic fundamental building blocks like D3 that you need for your immune system, you need to have this multi as just a go-to everyday take it because you don't have to, but you really need it. Most of us are magnesium deficient, so this will replenish that magnesium every day too, as well as give you the zinc you need to function and fight off disease, infection, and to heal injury. Glycine, again, for connective tissue, it is every third position in the collagen bundle in terms of amino acids, hugely important. Glycine also counteracts the effects of glutamate. Glutamate is an excitatory neurotransmitter. Glycine is a calming neurotransmitter. So glycine has a dual function. Omega-3s, better cell membranes, more flexible cell membranes, far less inflammation. And coincidentally, your triglycerides will drop. Again, all of these things have great health benefits besides making you feel better, as opposed to the synthetic drugs that have side effects that make you worse and may or may not help you feel better. Tart cherry, we talked about. Joint Health Multi, we talked about. So that's the stack if you think you're more of a connective tissue player versus a pure arthritis player. And your doctor can help you determine this, or if you come see me, I can. And then oxidative stress. Again, just to refresh, and we did a whole talk on this before, This is the reactive oxygen species that are the byproduct of energy production in the mitochondria, okay? And also the byproduct of pollution, toxins that we take in, things like that, okay? Radiation, sun radiation, whatever. So you have to capture these free electrons before they damage cell membranes, before they damage DNA, before they damage proteins. That's why you take antioxidants. That's why they're so important. So all of these have very high levels of antioxidants that can help. We talked about the alpha lipoic acid, which has been studied and is a first-line treatment in many countries for neuropathy to reduce inflammation around nerves. We talked about NMN, which captures electrons and helps move them around to improve your energetics. We talked about D3 and B12 and magnesium. The Mindset Gummy is awesome to give you extra D3 and B12. I take one a day in addition to my connective tissue multi. The Energy or the Brain Booster series has those beta glycans from the mushrooms and a lot of them from different mushrooms, because in nature, we have what's called the entourage effect, where you get a lot of benefit from a group of components. So like when you eat a meal, you're not eating a single molecule that's highly controlled, right? You're eating massive numbers of molecules that all work together to get you better. Most of medical science doesn't work that way. We never look at groups of things all together with 100 different variables. We are only allowed to look at one molecule at a time, or it's not considered valid. That's not how the world works or the universe works. So you want the entourage effect. So the Energy has beta glycans from different types of mushrooms, along with a lot of other antioxidants from the natural world. And then the CoQ10 we talked about. Again, really good if you're on a statin for sure, but take it anyway to help your bioenergetics if you find that you're feeling fatigued, have brain fog. And they've actually studied it. There's a lot of good literature out there on migraines, taking CoQ10 for that. So get good mindset, get exercise, especially resistance training, eat a good diet, and sleep well. Those are your fundamental building blocks to treat your arthritic symptoms naturally. But short of that, if you can't get a perfect Mediterranean diet, here's your supplement stacks to help you with the building blocks so that your cartilage can repair itself, because it can, so that you can reduce pain, because you can, and so that you can get more mobile and improve your function, because you can. And so you don't have to have that surgery just because your x-ray looks a little bit goofy or your MRI shows a tear, because you don't have to. Now, you may or may not actually need that surgery down the road, but if you do everything I just talked about, odds are that your outcomes are going to be leagues above where they would have been otherwise. So it's win, win, win all around. I'm just giving you the alternative viewpoint besides the pure reductive, here's your tear, fix it, or take this drug and don't do anything that hurts it. You don't want that robotic response. Start thinking about outside of the box, how you can treat this yourself and empower yourself. Hopefully that helped. If anybody's in questions, we'll answer it. Otherwise, go enjoy your Sunday, and thank you for learning with me and letting me teach.